Dear friends, first of all, I'd like to thank you for the invitation. It's a real pity that I cannot be in presence with you today. My task today is to talk about the genital syndrome of menopause and its relevance in the management of postmenopausal women. As you know, the genital syndrome of menopause is the new definition that include both genital, sexual, and urinary symptoms, and is a chronic condition that is defined as the collection of symptoms and signs associated with the decrease of ovarian steroids production, involving changes in labia, clitoris, vestibule, and the vagina, as well as the urethra and the bladder. And we all know that all these symptoms can have a very important negative impact on quality of life of postmenopausal women. We know that despite its relevance, the GSM is largely underreported, under-recognized, and therefore undertreated. We used to think about the GSM or vulvovaginal atrophy as something happening in the late postmenopausal years. But please take into consideration that this is not really the case, because up to 20% of the women, according to the Italian Menopause Society studies, are reporting vaginal dryness and objective signs of vaginal atrophy when they are in their early 40s. Clearly, the increase in GSM is parallel to the aging and going up to 85% of the women 6 years after menopause. So the GSM is a very big problem for peri and postmenopausal women, not necessarily elderly postmenopausal women, but even young perimenopausal women can suffer from the GSM. So ask and tell. The problem is that we don't ask, they don't tell, and we don't treat sufficiently. And we have to take into consideration that the hypoestrogenism in general can affect the vagina health, not only after menopause, after natural menopause, but also after primary ovarian insufficiency, surgical menopause, and always women with a surgical menopause, they suffer with a severe GSM also because they do have a sharp decline of circulating androgen levels, and also women suffering from hypothalamic amenorrhea or postpartum state and breastfeeding, they do have hypoestrogenism, as well as the women treated with GnRH analogs or aromatase inhibitors. They can suffer from severe GSM. And please take into consideration that often these women are very young, younger than 50, treated for maybe not only fibroids, but also for the breast cancer for ages and years. And they do have a severe GSM when they are very young. And also the terrible effects of radiation therapies on vaginal health must be taken into account, and we should have a particular attention to women treated for colorectal cancer and irradiated for colorectal cancer, for example, that they do have severe effects in terms of vaginal atrophy. How we do need to evaluate women with GSM with the history and the pelvic examination, and take into account that the women's symptoms not always correlate with physical findings. And we need also to consider that in the absence of symptoms, not always we need to treat the atrophic changes, but we do need to inform our patients that these changes, even if they don't provoke any symptom at the moment, they can worsen over time, and without a proactive management of the atrophic changes. So we needed to follow different principles in managing the GSM. So we need to locate the discomfort, if it is on the vulva, clitoris or vestibule, the vagina, the pelvis in general, and consider that sometimes we do have more than one entity, and consider the symptoms separately, because sometimes women, they may have different entities that they need different treatments. For example, atrophy and inflammatory changes, atrophy and infections, and we should use the pH measurement and wet microscopy in particular cases. But definitely we need to have a follow-up visit 2 to 4 months after for an initial follow-up. And sometimes we need to perform a biopsy for dermatological conditions resistant to the treatment. And these are rules that can help us to reach our goals. So we need to treat women in a stepwise fashion based on symptom severity, and we need to counsel a patient saying that the symptom reduction may take up to 3 months, and the continuous treatment is required because the GSM is chronic in nature, and therefore symptoms are likely to recur on cessation of treatment. And our goals should be to alleviate the GSM and VVA, but also to preserve and improve sexual function in postmenopausal women, and maybe we want even to prevent GSM effects on women's quality of life and sexual life. As an Italian Menopause Society, we wrote this recommendation jointly with the Italian Society of Third Age for the treatment of VVA in peri- and postmenopausal women. And first of all, we need to underline the relevance of preventive educational measures. So saying that mucosa responds to the mechanical sexual stimuli with the preservation of trophy and lubrication. Therefore, we need to promote sexual intercourse, and if needed, the use of endovaginal stimulators with lubricants, and if needed, lidocaine gel with local anesthetics, in order to have the possibility also to use vaginal dilators when the shrinkage of vaginal tissues are so important that women need to dilate the vagina using both lubricants and local anesthetics in order to cope with these exercises. And first of all, we have to counsel our patient not to use soaps. Not cheap soaps, not expensive soaps. Soaps are soaps. We want our patient use oil, milk, gels for intimate care. They are very effective for superficial dyspareunia. They do have a very good compliance. We do have a lot of these products in the market, but please use only oil, milk, or gels. Lubricants are very, very effective, but They must be used during intercourse, and sometimes they do interfere with sexual life, and therefore women are not keen to use the lubricants for ages. The same may apply to vaginal moisturizers that are promoting rehydration, mimicking the effects of vaginal secretions, but they need to be used frequently. The frequency can range from every day to 1 to twice a week. And we need to keep an eye on those moisturizers that our patients are using, because some of them can alter the pH, and their osmolarity can be of danger for vaginal health. And so the content of these moisturizers can even interfere with vaginal health, promoting the herpes infection, bacterial vaginosis, and even candida infections. And therefore, we must counsel our patient in choosing the vaginal moisturizers. Other agents for non-hormonal treatment of menopausal symptoms are bovine colostrum, vitamin D, and oxytocin containing products. I don't have any experience because we do not have these products on the market in Italy, and they have been reported in the literature having some benefits on vaginal symptoms. But the vast majority of physicians are treating postmenopausal women with hormonal treatments, including local and systemic treatments. The local treatments are very important because local is logical. Approximately 40–50% of the women taking systemic HRT are still presenting vaginal dryness and dyspareunia, and they do need local treatments. There may be some local hormonal treatment. So we need to integrate local HRT with systemic HRT. And we do have low-dose vaginal estrogens and even DHA or progesterone, and the oral administration of a new serum or spinning. In the HRT prescription flow chart, for the systemic HRT, we need to take into consideration the age at menopause, the presence of contraindication, and so on and so forth. But for local treatments with low-dose estrogens, even symptomatic women over 60 and over 10 years after menopause can be safely treated with local estrogens. And even women having some contraindication for systemic estrogen administration can be treated with local estrogen administration very safely. We do have a lot of different estrogen preparations, from C cream, the conjugated equine estrogen cream are not available in Italy anymore. They do have some systemic effects. We need to take into account that the absorption of conjugated equine estrogen can have systemic effects, while the use of promestrine, low-dose estradiol with 10 micrograms, estradiol 7.5 microgram release with the vaginal rings, or the estriol administration in different preparation with different strength from 1000 micrograms to 30 micrograms a day, with vaginal suppositories of 30 micrograms a day, are very effective. There are no head-to-head comparison studies, and therefore we cannot say which one is better than the other. And the choice may depend on clinical experience of each one of us, and also to patient preferences. They may need creams rather than suppositories, rather than gels. But please take into consideration when we use, for example, the ring. The ring, we do prescribe 7.5 micrograms every 24 hours. And when we do prescribe 1 milligram, 2 milligrams of 17-beta estradiol, the dose is equivalent for 9 months of ring treatments. So we cannot compare the strength of local treatments with the strength of systemic HRT administration. Therefore, we need to underline the fact that the HRT does not exist. We do have different HRTs that are that we can personalize with for our women, and remind that the American Urological Association underlined that the vaginal estrogens are important for the prevention of recurrent urinary tract infection in postmenopausal women. So when women do have many urinary infection, we need to prescribe vaginal estrogens in order to prevent and reduce the recurrent urinary tract infections. This is vitally important for the quality of life of our postmenopausal women. Having said that we do have different HRT preparations, different estrogen therapy preparations. We do have Prastron DHS. We do have the oral SERM, the ospemifene. I'd like to spend 2 minutes with you talking about the vaginal erbium laser. Why the vaginal laser? Because the vaginal lasers are very effective in reducing the genitourinary symptom menopause. I'd like to underline these data obtained with Marco Levancini in our department treating breast cancer survivors, very young women. The youngest, she was 38, and she was suffering from vaginal dryness and dyspareunia. And you see that the effects of 3 different laser applications that reduces both dryness and dyspareunia, and the effects are lasting more than 1 year. These are data obtained in 200 women in our department, and we see that we do have a reduction in dryness and dyspareunia for more than 12 months. And the vast majority of these women, they request another course of vaginal laser after 12 to 18 months. So even if this study was not randomized controlled trial, we see that the effects of vaginal erbium laser is at least as potent as local treatments. But when you stop local treatments, we see that after 3 to 6 months, the symptoms that occur in terms of dryness and dyspareunia, while the vaginal erbium laser treated women, they do have benefits up to 12 months. And we do have over 50 prospective studies regarding GSM and stress urinary incontinence. And by the way, for stress urinary incontinence, we do have also 2 randomized clinical trials, one with 1-center trial, 1 multi-centric trial, showing the benefits of vaginal erbium laser, not only on the vaginal symptoms, but also on stress urinary incontinence. And the effects are very important in terms of sexuality. These are a multi-centric study in Italy over 569 women. These are the FSFI score improving after the treatment up to 6 months. And these are the data collected by the Vaginal Erbium Laser Academy around the world. More than 130,000 women treated with vaginal erbium laser. And please, dear colleagues, take into consideration that the major adverse effects were absent, and the most reported adverse effects were vaginal discharge in 4% in the of the patient. The overall frequency of vaginal discharge, annoying vaginal discharge, was 4% of the postmenopausal women treated with vaginal erbium laser. So it's very effective and very safe. We can say that with the Vagina Smooth, we do have large databases and long-term studies. And I'd like to show you just one slide with a new technique we have been using in our practice for the treatment of superficial dyspareunia, for the treatment of vestibulum and the posterior commissura that is causing the pain at the vaginal opening during sex intercourse. And you see all these women suffering from superficial dyspareunia treated with a new protocol pairing both erbium laser and the YAG piano mode to treat the vaginal with a vaginal non-abrasive photothermal treatment, including the smooth mode and the piano mode. And make a long story short, these are our first patients treated with the vaginal erbium laser plus and neodymium YAG. And you see here that according to the selection, all those women that were suffering from superficial dyspareunia, you see the superficial dyspareunia decrease with the vaginal erbium laser classical treatment. But when you add the neodymium YAG treatment at the posterior commissura, the effects are more relevant and statistically significant, and the effects is more pronounced. And with having said that, dear friends, I'd like to say that nowadays we need to think about integrated therapies for GSM, not only local treatment, not only rospimifene, but also non-hormonal therapies can be paired with hormonal and non-hormonal treatment. And nowadays we have to say that the vaginal erbium laser is something that is a reality and cannot be denied to our women. Thank you very much for your kind attention.